less intimidating. Hi, everybody. My name is Tammy, and I'm a registered nurse with a master's with a concentration in population health. And I also have a certification in addiction nursing and psychiatric mental health nursing. Just a little bit about myself. I'm not only speaking to you today as a nurse, but also as a person who has lived experience. When we think of lived experience, a lot of times we think of people who have substance use disorder and who have been through it. But there's also all of those people out there that are on the other end of it, the family members. And I'm one of those family members. So several of my family members live with addiction, and many have resulted in substance use disorder. The most difficult one that I've had to kind of maneuver is heroin addiction. And that really kind of knocked me back. It forced me to learn about addiction. I didn't know anything about it up until that point, even though I've been a nurse for almost 30 years. I mean, I knew the basics, but until I learned about the neurobiology of addiction, I really wasn't able to help my daughter. And it was who anybody in this room who knows the feeling knows that it's terrible. You're planning your child's death every day. You're planning for grieving somebody that hasn't even passed away yet. It's a terrible feeling. Luckily, she found recovery 6 years ago, so she's in recovery. But with that, I really dove into addiction and learned everything I could about it so that I could help other family, especially family members of those who have people suffering from substance use disorder. So a lot of this presentation is going to be about how we can meet the patient using harm reduction techniques, not necessarily physical harm reduction techniques, but more of like a philosophy of care. But also, I talk a lot about supporting the family and involving them in care because I think that that's really important. So here's my disclosure. The only conflict I might have is I say harm reduction a lot in here. And if anybody was here yesterday, I guess the government is not really too big on that anymore. So just making a joke.
Yeah, we're not the government, we're good.
All right, so here's my objectives. Notes right here. Okay, so keeping it simple in the beginning, harm reduction is not whatever happens, happens. It's not anything goes. It's not only meeting people where they're at, but also helping them along in their journey. So you don't just meet them where they're at, walk with them along their journey as they progress. Harm reduction is not helping someone who has stopped using drugs to start using them again. And it's not condoning or endorsing or encouraging drug use. A lot of people have heard of Johann Hari. He did a TED talk on the opposite of addiction is, I'm sorry, the opposite of addiction is connection, and that's in the next slide. And I strongly feel that the opposite of addiction is not sobriety because a lot of people don't want to be sober. They want to decrease their use, they want to safely use. So, whatever goal our patients have is where we need to meet them at. So what is harm reduction? Like I said before, I don't want to talk about, although it's wonderful, the clean needles, the fentanyl test strips, love those, always promote them. But let's talk a little bit more about it as a philosophy of care. So reduction of negative outcomes, respect, rights, patient-centered, judgment-free, increased access to services, improved workforce recruitment and retention, and that includes hiring people with learned experience, taking stigma, achieving parity, improving service delivery, welcoming, inclusive, full range of services, and readily available. And all of these words probably kind of hit points that other speakers before me have talked about in detail. It was kind of cool how listening to all the speeches before getting to mine and how everybody kind of had the same, not information, but kind of the same outlook on things, but just different presentations. So a little bit of statistics, and I looked this up on the CDC and they're a little bit behind. So that's why it's 2023. The top is 34 jurisdictions throughout the United States, and the bottom is Massachusetts. So this slide reflects the number of overdose deaths in 36 jurisdictions throughout the United States through 2020 and 2023, and also in Massachusetts. Now, the thing that we notice about this and that we've heard in the previous presentations is that the deaths, overdose deaths in Massachusetts from 2022 to 2023 went down quite a bit. And that was, I think, largely due to the saturation of Narcan that we were giving in the community and all of the harm reduction education. However, the last column is where I want you to focus, because this is the percentage of these people that passed away where we had at least one opportunity to intervene before they passed. So those are all above 50%, and most of them hover around 60, 69%. So the number of opportunities went down in the US, and then in mass, they went up and then they went down again. But these numbers to me prove two things, and that is, one, opportunities are decreasing. The barriers to care and isolation caused that. And when the opportunity was there, it was missed. And that proves that we have a big lack of education among people in the community. And just to tie into this a little bit, when I was in the ED, I work with Maria over at Holyoke, and we had a patient who had Narcan, and she was leaving AMA, and I asked her, do you have Narcan? And she said, yes, I have it in every single room in my house. And I said, that's great. And she lived with roommates, and I said, do your roommates know where it is? And she said, yes, they do. And I said, do your roommates know how to use it? And she said, no, they don't. So that right there shows you that along the way that she had gotten all those Narcans and everything, nobody ever really bothered to inquire who she lived with or if they knew how to use the Narcan. So it's really important for us as healthcare workers to kind of do the digging and figure out who the support systems are and make sure they're just as educated as the patients. So this breaks down the missed opportunities in Massachusetts alone a little more, 2020 versus 2023. So it shows you where the areas are that the missed opportunities were in, and those include current treatments for substance use disorders, fatal drug use witnessed, evidence of a mental health diagnosis, potential bystander present, and prior overdose, and the decedent was recently released from an institution setting. So what do you all kind of notice about the two comparisons? What's the largest area of deficit that we have the missed opportunity in? The blue, right? The bystanders. So that means we're not doing a really good job at educating our communities, right? And then the second one is mental health. So that means that somebody that has a mental health diagnosis and is using to treat the mental health diagnoses, that got missed and their mental health diagnoses did not get captured. So what we need to do as healthcare workers and experts in this field is we need to educate our peers that these things are happening and have them help us get the information out. This is just a little timeline of the history of harm reduction. We've done this before at other presentations, so I'm not really going to get too much into it, but it just shows you that methadone was in use as early as 1964 and kind of how it progressed. It wasn't until 2009 that federal funding was used or able to be used for syringe purchase. Prior to that, it was just being used for the programs themselves. Also to mention on here is Attorney General Maura Healey was the first state attorney general to sue Purdue in 2018. And the resolution included a $4.3 billion settlement, of which 90 million would be funneled to Massachusetts. And as you heard earlier today, people are still trying to fight for where those fundings are being spent. So this is across the United States. As a result of the timeline that you just looked at, there was an international drug strategy developed, and it included the 4 pillars: prevention, treatment, law enforcement, and harm reduction. Even though harm reduction is only one pillar under there, it commonly will be referred to as harm reduction, the whole drug strategy. And that's appropriate because all of those things that fall under that under that strategy are included in harm reduction services that we provide, right? Prevention, treatment, law enforcement, and harm reduction. I think it was Dr. Hernandez earlier said that sobriety or recovery is harm reduction. It's the same. It's not, there's many things that you can do even when somebody is 100% sober to provide harm reduction. So we're going to talk a little bit more about the harm reduction column because SAMHSA had the first, there was a first ever harm reduction virtual summit hosted by the Office of National Drug Control Policy, the CDC, and SAMHSA in December of 2021. And this was a significant turning point for harm reduction. As a result, SAMHSA steering committee used the findings of the summit to develop this harm reduction framework. And this is the framework that we should all be following when we practice our harm reduction in our agencies. I'm not going to get too much into it, but the first one is led by people who use substances and with lived experience. And as we talked or learned before, people with histories of substance use or family members have the best input and know how to best put together programs and serve people who are suffering from substance use disorder. The second one is embraces the inherent value of people. The third is commits to deep community engagement and community building. And that I think is a really big one. I think a lot of times that we really work hard on treating our patients and trying to find out what the newest drugs are that treat substance use. But I think sometimes we lose sight of the simple things that are still there that we can do, like going out into the community and educating. And while you're waiting 30, 60, 90 days for the Sublocade to get approved, you know, you could be doing this other stuff that could just as well be keeping the patient safe and healthy. Promotes equity, rights, and reparative social justice. Offers more accessible and non-coercive support. And focuses on any positive change. And this is a huge one. I was talking to Maria about this earlier. A lot of times when people come into practice for follow-up visits, one of the first questions that they get asked is, you know, how'd you do? Did you use? When was your last use? And I know a lot of us don't approach it that way, and that's great, but there are a lot of places that still do. And I think that we need to help to create like an environment where we're focusing more on their accomplishments, so whatever their goal is. So if their goal is not to become sober, but their goal is to decrease their alcohol use by working on other coping skills for their anger because they drink when they're angry. Then when they come in, maybe they want to tell you how many times they didn't get angry last week or, you know, something along those lines, as opposed to how many times they drank. So within these pillars, there's 12 different principles or actions, and these are actions that we can actually do within our practice to help support and reinforce people getting recovery and follow the harm reduction framework. We always want to respect autonomy, practice acceptance, provide support, especially with the peer-led services, connect with family members and community, and that's a big one. We'll talk a little bit more about that later. Provide many pathways to well-being across the continuum of health. And in one of the presentations earlier, the speaker talked about all of the different pathways like AA, NA. There's a book at the end of the presentation on the last slide that I'll show you that is a phenomenal resource that we got at the hospital with the multiple pathways to recovery. You all might have it. You can get it through the clearinghouse. And there, I'll show it to you at the end, but I think there was like 41 different approaches to support groups or ways to support your patients. And like, that blew my mind because even though I knew about like Smart Recovery and Celebrate Recovery, I never knew there was 41. And I'm sure there's many, many more out there too. sorry, I wasn't done with this one yet. Value practice-based evidence and on-the-ground experience. When you're meeting with your patients, make sure you know what you're working on with them and whether or not it's been proven to work in the past, right? We don't want to be reinventing the wheel or doing things that have not proven successful. You want to make sure you cultivate relationships. You want to assist, not direct, promote safety, engage first, and prioritize listening and work towards system change. And then I want to go back to promote safety for a minute because that should be as defined by the people we're serving. What is safe for them? Not what we feel is safe, what they feel is safe. Okay. So lastly, with the harm reduction framework, it includes 6 core practice areas that bring alive harm reduction approaches, initiatives, programs, and services. These practices allow us to reflect community understanding, experiences, strengths, and need. So the different areas are safer practices. This is where kind of the safer smoking supplies comes in, the syringes, STI screening, wound care supplies. It's kind of all the physical stuff. Safer settings, we want to make sure that we provide our patients with low barrier settings so that they're able to come in and get services without a lot of hassle. And the other thing too is if you don't have the service to, and this is, I feel very passionate about this and I say it all the time. If you don't have the services to provide to your patient, you should get them where they can get it. And it should be right then and there. It should be a warm handoff because that one touch would be maybe the only time the patient is coming in for help and you may never see them again. So that is super, super important. That was helping a colleague that I work with over at the detox or the withdrawal management facility. I'm helping him. He's got a startup company and he's doing virtual home detox. And so I'm helping him kind of set up the program and the nursing piece of it and everything. And the first question that came out of my mouth when they started talking about the process for, okay, the call comes in, then it goes to this person, then it goes to this person. I said, hang on, back up a minute. When the call comes in and we can't help them, what do? We're not hanging up on that person, are we? And I made that like really, that was a strong selling point for me to kind of help them out. I said, you know, that I'm huge on harm reduction. And if we have somebody there, we need to help them. All right, so safer access to healthcare. We talked about earlier, kind of combining services so patients can get several treatments in one location. Safe transitions to care, again, warm handoffs to and from the ED, low barrier MOU services, and post-OD services. And also on-site immediate referrals for housing, nutrition, clothing, shelter, and assistance. And then the sustainable workforce field, we want to again make sure that we're having staff that have lived experience and making sure that their wages and benefits match those of everybody else. Okay. We want to make sure that we support our staff and make sure they have the education and knowledge that they need to provide. And we also want to make sure that they have the wellness services available to them too, so they don't burn out. And then the sustainable infrastructure. This is kind of cool because this is where you would include people who use substances in your policy development. So have your patients get involved. They're the ones that have their feet on the ground. They're the ones that know what's going on. And they're the ones that can help us make sustainable policies that work. All right, keeping all this in mind, we're going to switch gears a little bit, and I'm not going to beat this to death because we all know how many change barriers there are to people that want to seek treatment. The one that I want to, oh no, it's not on this slide, never mind. So these are all change barriers that people encounter when they're trying to involve themselves in care. And almost every single one of these change barriers can be attributed to 2 things, either stigma or lack of education. So those are the two areas that we really need to focus on as healthcare providers. And just a little interesting fact, during my research, I read a systematic review of barriers and facilitators to substance use disorder, in which they identify that the majority of research indicates that the family has a distinct impact on SUD compared to the rest of a person's social network. So we really should be focusing on the patient's family with their care. I mean, we all give really good care, but I can't think of any of my settings where that happens consistently. We're involving the family, especially in the detox setting. That should happen all the time because that's like their first step into treatment, and the family needs to know how to be able to support that. Okay. So, how does success start? Success starts by educating clients, families, community, and stopping the stigma. We're going to talk first about education. And the reason why we're going to talk about education first is because when people have more education regarding the disease of addiction, the stigma will decrease. And Dr. Nora Volkow, who's the director of the National Institute on Drug Abuse, had done a blog where she wrote that the significant impact or lack of access to services, the significance it can have on those with substance use disorder, and how it's definitely a direct result of the healthcare system not receiving proper education on how to support this population. And you heard Maria earlier, she said she had like 1 hour when she was in her schooling. So there's not a lot of education that goes into programs before we graduate. So it's up to us to kind of get the information that we need to help people. Understanding the neurobiology of addiction is very important in relation to providing a client with substance use disorder the empathy and understanding they deserve. With understanding of how addiction works, we can view the diagnoses as a disease as opposed to a choice, which can result in a significant decrease in stigma. So on the organizational level, these are the areas where we can either provide our staff, our organization, or sister organizations with education to help decrease barriers, making organizations more low threshold, drug testing for non-punitive purposes only, same-day prescribing, changing the structure of the program for easier access, warm handoffs, comprehensive screening. I know you guys might think that's the next one's silly, allowing pets, but I like that one because it came up in the literature. But also, I always remember a patient that I had at one of my MAP programs that I worked at who really needed to go for inpatient withdrawal management services before he could start Vivitrol or naltrexone, and he would not go because he had a pet at home. And I'm thinking, gee, why can't we there's a shelter right next door. Why can't we like partner with them and volunteer over there or something and then have them keep people's animals for a couple nights so they can go to detox?